Welcome to this second lecture on general examination. Joel Vaughn again with you, and this is the second brief and condensed lecture on general physical examination to get you guys ready for your lab sessions during this part of the semester. So we already talked about the first lecture, and it's mainly about the process in general. Where does it fit in the consultation? What are the general steps with which you begin? The inspection, the palpation, the percussion, the auscultation, and just in general beginning well with the examination process. And now we're going to move into some more specifics. And what I want to emphasize with this lecture is that first impressions are very, very important. There are many, many things you will learn within a few seconds of seeing a patient that will inform your thinking about their medical problems. You'll notice many things about them within a moment, and that will help you figure out what their problem is and how you can help them. And again, we want to help them because we love people. People are great. People are valuable. People are made by God. So McLeod says, and I wholeheartedly agree, the physical examination starts as soon as you see the patient. In other words, there is a time in the consultation when we say we're moving to physical examination and we're examining specific body parts at that point. But in truth, the second you lay eyes on the patient, when they walk into your office, when you walk into the room where they're sitting, you learn many, many things, and the physical examination starts then. So what will you notice? Well, as the patient enters the room or enters your clinic, you notice their gait and their posture. And over here you have some examples of abnormal gait and descriptions of them in McLeod's. Certainly you can look up some videos online. I didn't want to make the PowerPoint too data intensive, but you have people have to swing their leg around when they walk, this spastic hemiparesis. Maybe they had a stroke previously. You have this steppage gait where they step really high with their feet because they've lost their position sense because of nerve damage. What you want to notice about this one, sensory or cerebellar ataxia, it can occur for a lot of different reasons, many different disease states, including just being intoxicated with alcohol. Sakranyani, where you have a wide-based gait. Your feet are out wide and you're kind of shuffling to keep your balance. And then lastly, the Parkinsonian gait, where the patient's stooped over, the head and neck are forward, and it's just really hard for the patient to initiate movement and to start walking, and they walk very stiffly because of the rigid muscles they have. So that's just one example of something you'll notice immediately when you see a patient. Their posture, if they're sitting in the room, you'll notice, are they sitting up straight? Are they slumped over? Are they lying down? All of these things you'll notice. Are they conscious or not? You'll notice this. You'll notice their facial expressions, their demeanor. Do they look anxious? Maybe they actually are anxious. Maybe they have a disease like hyperthyroidism or thyrotoxicosis that's making them look anxious, but it's a result of their medical illness. Do they look depressed? Do they look angry and upset? Again, that could be a result of medical illness, or they could actually be angry and upset. You'll notice all of these things immediately when you walk in the room, and you should observe them. These are things as a human being you'll notice about any human being when you first meet them. What we want to train you to do is to begin to put these observations into your database of information about the patient to help you make medical decisions with them for their good. You'll notice their clothing. Are they dressed really, really well? Or are they dressed shabbily? Are they wearing their pajamas in your clinic? Could they not get dressed because they're so ill or because they're so depressed? That kind of thing. One example of this is we used to have a patient that would come into the hospital in America who had sickle cell disease. And he'd come in with severe pain because of the sickling of the blood cells in his bones and tissues. And you always knew he was feeling better and ready to go home when he got up, got dressed, and put on cologne. So when you walked in the room and he was smelling really good and looked like he was dressed to go out for the day, you knew he was feeling better and ready to be discharged from the hospital. So their dress and how they put themselves together really does give you a clue about their well-being. You know, you'll also notice their coloring. So after they kind of, walk in the room, or you walk into the room and see them sitting, you'll also notice some other things about them. There's an example here of pallor. Maybe they look very white. And that white color, and you'll notice it mainly here in the conjunctiva, could indicate anemia, a loss of hemoglobin. Now, we don't know why. There are several reasons why someone can be anemic, but nonetheless, you'll notice a pale color. One time I diagnosed colon cancer that way. The patient, I walked in the room and he just looked very white. He also looked tired and fatigued. And it turns out he was very, very anemic because he had a colon cancer that was bleeding and leaking blood. Cyanosis is an important one. This is an example of central cyanosis when it's around the lips and mouth, this blue kind of coloration. And that's very, very serious. It indicates low blood oxygen levels at the heart and lung level, and therefore the rest of the body is experiencing that too. And that's something you got to move on very quickly. Versus if it's just the hands and fingers, we call that peripheral cyanosis. And that is not typically as serious. It's usually a reaction to very cold temperatures or some other medical problem, but not necessarily a life-threatening condition like central cyanosis could be. Maybe they have a pulmonary embolism. One time I went to go see a patient in the psychiatric hospital to do a medical consultation because they weren't doing well. And when I got there, the patient looked blue. They were cyanotic. And sadly, the patient died within minutes of me arriving because they had a large pulmonary embolism, and we were not able to get it reversed in time, so the patient died. And then lastly, jaundice. I don't have a picture of that here, but that's that bright yellow coloring you get with liver disease. Most notable, as is pallor, as is cyanosis in some ways, in the face. Jaundice particularly, and anemia particularly, the mucous membranes look very pale. The conjunctiva look very pale with pallor, and they look very yellow. And the sclera, the white part of the eye, looks very yellow with jaundice. That's a really easy place to look, especially when people have very dark skin. It can be difficult to pick up some of these changes, so we look at the palms where the skin is lighter. We look at the eyes and the whites of the eyes and the conjunctiva and the mucous membranes because they're lighter and easier to see these changes. We'll notice the smells. So it's not just the sights, it's also the smells. And that could just be somebody who's unkempt and is not feeling well enough to shower, or maybe they have schizophrenia and they just don't take very good care of themselves. But you also have some characteristic smells of medical illness. We say acetone with diabetic ketoacidosis, and I'm sorry, the fonts are a little weird on that, but basically it's a fruit smell. The smell when you go into a fruit stand and you kind of smell that aroma of the fruit, that's acetone in the air. So a diabetic patient will be metabolizing fat and breathing out acetone as a result, which gives that fruity smell to the room when they have diabetic ketoacidosis, which is obviously a very serious illness. If they have a fishy odor, maybe they have uremia due to kidney failure. A mousy smell with hepatic failure, that's hard to describe. All I can say is when you smell it in a patient with liver failure, you'll remember it and you'll notice it forevermore after that. And then a foul smell, a smell like stool in somebody who has gastric outlet obstruction. In other words, they can't empty their stomach. It's a horrible, horrible foul smell when they're breathing from that. And again, these are all clues that I need to do some things quickly for these people. And then there are things you'll just notice. It's a combination of factors. It's not just one thing. It's a combination of things that you'll notice in certain patients. So what we call a spot diagnosis. Down syndrome is a good result. I didn't put a picture here because I think all of you guys know what that looks like when you have that trisomy. But Down syndrome is a good example. It's an immediately recognizable set of features that tell you one of the problems the patient has. And there are other things like that as well. You have the hemorrhagic telangiectasias of hereditary hemorrhagic telangiectasia here. These are more complicated ones, more rare ones that you won't be as familiar with like you are with Down syndrome. So I wanted to put some examples up here. As you guys learn more, you'll recognize more and more of these things. This would be systemic sclerosis or scleroderma, where the nose looks more like a beak and the lips are very tight and drawn up. The face just looks very tight and leathery. And you'll notice that immediately. I've seen that in several people here just at the grocery store and things like that. It's a very serious illness. The bright blue eyes of somebody with osteogenesis imperfecta, who is going to have very soft bones and a lot of fractures. And then lastly, just an example of a myotonic disease where the patient can't hold their facial features. They just look very flat, right? It's just they have hypotonic muscles in the face because of their medical condition. So just all these things you can recognize as you excuse me, get to know medical illnesses and start to treat patients. Okay, let's talk about hair. So once I've just kind of had this initial impression of the patient when I walk in the room, then I kind of think about moving from the top of the body to the bottom of the body, just other things you want to notice. And we include these things in the general examination because in truth, these are important with every single patient. Every body system we evaluate has a specific exam. You know, maybe it's the cardiovascular examination where you're going to focus on the chest, but also on the pulses. Maybe it's the gastrointestinal examination where you may focus more on the mouth and the abdomen. But these other things really, really do matter. And so every examination of a body system needs to be accompanied by this general examination. So I start with the top of the body and note the hair. Have they lost hair? And some examples of hair loss are alopecia areata, alopecia totalis, where alopecia areata is just you lose small patches of hair on top of the head. Alopecia totalis is the whole head loses its hair. And then alopecia universalis, that last one is the whole body loses hair. You can also have excess hair. You could have hirsutism, which is most notable in a female when they get sort of a male androgenic hair pattern. Maybe they start to grow hair on the face like a male would and in other areas. So that typically has to do with too many androgens, too much testosterone in their body. Maybe they have a tumor secreting it. Sometimes this goes along with metabolic syndrome or polycystic ovarian syndrome. So again, you'll just notice it and realize there are some medical conditions I need to consider. And then hypertrichosis, where you're getting it kind of in an abnormal distribution throughout much of the body. And that can be due to some systemic illnesses as well as medication at times. And these are just some pictures. So here you have the hirsutism, a female growing facial hair. You have alopecia areata, where you have that patchy baldness. And then is this abnormal or normal? Well, you may say that's abnormal, but in fact, that is the pattern of male pattern baldness, with which I'm very familiar personally, where I guess you wouldn't say it's abnormal, but there's no medical disease you need to treat with that. It's just normal hair loss as a male ages due to the effects of testosterone in a normal male. So don't worry about that one too much. All right. Then I move down to the face and the tongue. The tongue can have a lot of different abnormalities. You know, you can have, excuse me, the kind of furry appearance on the left that a smoker might get. You have the glossy, shiny appearance with nutritional deficiencies. And notice here inflammation at the corners of the mouth. We call that angular cheilitis, and you can get that with iron deficiency. And maybe they're pale as well, so you notice they have anemia and iron deficiency. You can have white plaques on the tongue as well. And again, as the patient talks, maybe you have them open their mouth, or maybe you just notice as they're talking some of these abnormalities of the tongue. It can be a major clue to what's going on with the patient. And I could give you another example there. Once I had a patient who was talking to me, and I noticed some white specks on his tongue. So I had him open his mouth, and he had yeast plaques, so candida infection, all back in his mouth and in the throat. And it had nothing to do with why he came in that day, but we were able to make a diagnosis of HIV, human immunodeficiency virus, because I noticed that he had yeast growing in his mouth, and it was related to his problems that he came into, but it wouldn't have been obvious had I not noticed his tongue on general examination. And then we have fasciculation. So this is something you'll see with patients who have neurologic problems like amyotrophic lateral sclerosis, or what we call Lou Gehrig's disease in the US, where the tongue muscles move and twitch with no coordination. And again, a sign of very serious disease. Or back in the day, poliomyelitis might have presented this way. Fortunately, now we have good vaccines for that. So you want to notice the tongue. Also, this could happen, tremors could happen of the tongue, like if they have thyroid disease and hyperthyroidism, that kind of thing. Okay. As far as the hands and nails, as we continue moving down the body, you want to notice them. On the left, this is normal hands, but I wanted to highlight when you have very dark skin tone, like someone from Africa or someone from far south in Saudi Arabia or Yemen, you can still get a clue about the skin color from the palms and compare your own palms to theirs because the palms are lighter, right? So obviously here, more diffusely, everywhere on the body, it might be evident if there's a change of color of the skin or rash. It's less clear in the patient with darker skin, so you need to look more carefully and make note of where those changes are seen. You could look for deformity of the hands, like a Dupuytren's contracture, this is called, where the fascia, the connective tissue on the palm, starts to become scarred and to get shorter, and so it pulls in the fourth and fifth fingers. They can't straighten them because of it. And this could go along with various conditions, including liver disease, sometimes diabetes and other endocrine problems. So you want to make note of it. So hands and nails, they all go together. So what are we looking for in the hands and nails? Well, the color of the skin, obviously. Is there rash? Are there plaques, like you might see in psoriasis? Are there skin changes, like thickening of the skin? Now, this could just be because they work very hard and use their hands for their job, and so the skin is thick. Or it could be they have a medical illness causing thickening and cracking of the skin. So you want to make note of that. If they have a loss of androgen, maybe they can't produce hormones normally, they might have smooth hands and very hairless, no hair on the hands. The deformities, I already showed you Dupuytren's contracture. You also might notice muscle wasting, where it looks like there are ridges and valleys in between the bones of the hand. That could be from malnutrition or a neurologic problem preventing them from maintaining muscle bulk and tone in their hands. You can also notice changes at the nails. The nails are very important to observe. And maybe after you shake their hand, you just take a quick glance. But it's just one of these things where you'll notice one here, splinter hemorrhages. That little thing right there is a little spot of blood, and it can go along with bad problems like endocarditis, where you have an infection of the heart tissue. You could just have psoriasis, and it's caused some pitting and damage to the nails. Or when people get really, really sick, sometimes it will show itself in the nails. They get what's called a Bowes line, a white line of deformity across the nail that has to do with being very severely ill from some other reason. You have leukonychia, or these bright white nails. which can be due to low albumin with liver disease, low protein in the body. And these here go along with a variety of rheumatologic and inflammatory conditions where you get the nail capillaries becoming damaged and enlarged, and you can see them at the fringe of the nail bed there. And this is an example of a patient with systemic lupus erythematosus who has that. And then koilonychia, where the nails take the form of almost like a spoon. And again, has to do with, can go along with various nutritional deficiencies, that kind of thing. But you really want to notice the hands and the nails. We're just looking for clues about what is wrong with our patient and why they're there to see us. Clubbing is one that we'll just make quick mention of. This is an example of a clubbed nail. And what makes a nail clubbed is this diameter here, or this distance here, is bigger than this distance here. And that's abnormal. And when you feel the nails, you'll notice it's very boggy. And when you touch the nail, you notice it kind of shifts around a little bit. It's fluctuant, like we'll talk about with masses in the next lecture. So how do you check? Well, obviously you palpate, you look across the nail like we're doing in this picture, and this is, you can measure the angle and measure these depths, these distances here, or you can do this simple test here where you have them put their fingers like this, and if there's a little window there, like in this case, and this is a picture from the clouds if you need a better look at it, but when they put the nails together like that, there's a window you can see through. We call that Shamroth's window. A patient with Shamroth's window does not have clubbing. When they lose Shamroth's window, like this patient, they have clubbing. So that's a very good screening test for clubbing. And why, you would say, why do we care? Why do we care? So what? Their fingers look weird, their nails look weird. Well, typically it goes along with very severe illness. A patient with emphysema and COPD might have it when they develop cancer on top of their emphysema. People with congenital heart disease might have it. People with inflammatory bowel disease might have it. So you want to make note of it because it does indicate a major inflammatory problem in the body, and usually something very serious that it's a clue. You need to go looking for something bad in their body, okay? And that's it for this lecture, okay? So I just want to emphasize again, you're going to go through the general physical examination process, inspection, palpation, percussion, auscultation with each patient, with each body system. But before you even get there, you're going to notice things about the patient, their demeanor, their coloring, their posture, their gait. As you look closer, you'll just kind of scan the body from top down where you notice the hair, the mouth and the tongue, the hands, the nails, especially as you shake their hand and you get up close to them. You want to make note of these things because they all will give you clues about what the patient has, and you're getting these clues even before the patient starts talking. Now, we're still going to use our good consultation skills, and we're going to start open-ended, and we're going to listen really well to everything they have to say. I'm just saying you're learning from the second you see the patient, you're learning about them. Not just from what they say, but because of what they look like and how they move and what their mood appears to be. All of these things help you decide what's wrong with them, how can I help them, okay? So we have one more lecture in the general physical examination. There's part 3 that I would like you to watch, where we finish out what we do in general examination with some things that we can look at and quantify in specific ways, and then you'll be done. So thank you for your attention. If you have questions, write us on Teams, and we look forward to seeing you in the